Thank you for allowing me to talk. I do consider myself a junior researcher, but what I wanted to do is frame the discussion really today on what are the barriers that we have related to 4 general areas and organizational, institutional barriers that we have. Technical connectivity issues that we have related to research, data collection, and getting the rest of the story related to the patient related with research, and then recruitment and community engagement. So I'm going to go through my talk really quickly because I do want us to talk. So an issue that we have when we want to do a multi-center trial is IRB. For example, if I want to do a study where I'm recruiting from regional health centers, the health departments, things like that, who's going to consent my patient? Do all of those people in that site have city training? Which they don't. So this is a big barrier for me related to that. Also, what about differences in clinical practice? I was a little bit naive when I started a program. I'm not a heart failure expert or cardiologist. OB-GYN is my specialty area. But I was helping these nurse researchers in heart failure. And they said, well, let's recruit from these 3 practice sites. And I went, okay, well, that's great. And so we went through all of the protocols, have the nurse call center, the remote patient monitoring equipment set up, and the variety in practice that we found from one setting to another caused a few issues. So there's not just one way to treat a condition. So standardization of practice is an issue. So some solutions that are in or that will come. There is movement more towards a centralized IRB, online consent. So, for example, there is a smart IRB, and NIH is going to discuss the language in May related to that. So ideally, we could have a multi-center trial. It would go through one IRB instead of multiple IRBs. Then we could consent using the same protocol and recruit at all of those various settings. Standardization of practice, going back to Dr. Lowry's study with the ultrasonographers, we were kind of unique in our setting is we did QA and made sure all of those sonographers were adept at what they were doing. So we've got to think through those practice standards related to that. So these are things that are in the pike. And then also Brendan's suggestion about adding a 3rd arm to existing studies, I find that very compelling. And I think we also need to partner with other research trial networks, such as the pediatric trial networks, and see if we can add in telemedicine components to existing pediatric trials or other types of trials. So I think that's a thing that we can do to build on that. And going back to the centralized IRB, 64, the CTSA organizations that are funded all have smart IRB. So that's going to help facilitate research between institutions. Other things that we need to think about related to barriers is connectivity. So another remote patient monitoring project that we had, Arkansas is not mountainous, but half of the state is mountainous. So I had a pregnant lady signed up to do remote patient monitoring. Her readings would not transmit unless she drove a half mile up the road. And then the monitor connected, because she was too much in the valley. So connectivity issues still exist, even if I pay for the broadband or Wi-Fi access for my patients. And then another thing when it comes to remote patient monitoring, and I'm going to talk to Dr. Davis more about this, in Arkansas, we are one of the largest states in the nation. When I say largest, I mean the biggest. And so a traditional blood pressure cuff that comes with a remote patient monitoring kit does not work. So like the postpartum mHealth study that I did, I had to exclude patients who had an arm cuff size over a certain amount because they couldn't have their blood pressure read, or if they were below, or their cuff size was too small if they were one of those skinny moms. So those issues persist. So we went to an arm related to blood pressure cuff. Well, is it validated in a pregnant population? So now we've gone down a different research study saying, is this validated in pregnant women? Can we make clinical decisions off of a wrist blood pressure cuff? So those are things that we have to think about. So, here's just some of our connected sites in Arkansas where we do our teleultrasound. And there's an example of some of our remote patient monitoring. Then the other side of the story is data collection, originating site data. And so I'm going to talk to the telestroke folks out there or the burn trauma or things like that. Well, we know that we've given TPA, but do we really know the long-term story related to those patients? Did they end up in a nursing care facility? What were they like a year after telestroke? How do we follow up on the rest of the story related to these ED visits that we do? And that's very complicated. And I know those of you that do telestroke, you can get data for that exact encounter, but what about the follow-up data? What happens to that patient after they're seen? So that's an interesting thing for us to think about when it comes to things. EHRs, it's hard for us to centralize that data and have the same data collection methods. Then the other thing I want to talk about is recruitment and community engagement. What if we want to recruit people from the community setting and not necessarily from a doctor's office or a hospital setting? How do we get patients involved? So let's say we're going to do an educational intervention. How do we engage those patients? So things that we've done is community-based partners, and such as churches. We've enrolled people through churches, and then other community-based pregnancy programs. So these are just things to have us start thinking about the barriers and ways that we can do that gold standard randomized controlled trial related to patients.